My name is Andrew. I am a cardiologist here at the VA, and hopefully I will see many of you guys when you're doing your cardiology rotation here. I've been giving this talk for several years now, and I'd like to thank the organizers, Emily, for asking me to give this talk again. I like to keep it interactive, and that's kind of why I'm doing it here. So I'll probably ask people questions, and shout out the answers, or I might pick on people if no one wants to give an answer, but it's all just for learning and just to kind of, see what you guys think. But the real reason I'm doing this is just kind of give you a framework on how to deal with chest pain, particularly in the hospital and when you're on the wards. So let's see if my slide will move. There you go. Now it's moving.
Yeah, you might want to exit out of that okay up there.
Yeah, let me exit out that okay so I can see the slides. Okay, all right. So, of course, when you're dealing with chest pain, it's really, there's a lot of reasons people can have chest pain, right? So it's not always all cardiac, and in fact, a lot of times it's not cardiac. So, for example, you can often have panic attacks, and that can often present with chest pain. You can have musculoskeletal chest pain, and the great mimicker of cardiac chest pain is often GI symptoms. So like if you're having GERD or esophageal spasm, people can often present with chest pain, and sometimes it's kind of hard to figure out, is this cardiac chest pain or not? Today, we're really going to focus on cardiovascular chest pain, since I'm a cardiologist. That's what we're really going to be focusing on today. But you just got to make sure when you're approaching someone with chest pain, you come up with kind of a wide differential. So I think the most important thing when you're dealing with someone with chest pain, there's going to be some objective data that you're going to get, right? When you go at someone who's having chest pain in the ER, hopefully you'll have an EKG that you can look at, and you'll probably have a troponin that will help you. So all of those things guide you. But oftentimes the EKG may not give you an answer. And sometimes the troponin will be very helpful, and sometimes it's not very helpful. So in my mind, the most important thing is, well, one of the most important things, if you can't make a clear decision, yeah, this patient's having a STEMI, that's obviously something you're going to act on right away. But most of the time, it's not going to be so clear cut. So the history becomes super important, and I can't emphasize that enough. So when we think about classic angina, right? Those are the things that you've all learned about in medical school, and it's true. These are the classic symptoms people get. So, and you got to really tease it out, and sometimes the patients aren't going to be, it's not going to be just like textbook. So you got to filter out the things that may be not important and really hone in on the things that are important. So classic angina is usually presented with chest pressure or tightness. So I've had several patients that come to me and I've asked, do you have any chest pain? In the ER, I said, no, I don't have chest pain at all, right? But you got to make sure you're framing the question, because I tell them, well, are you having pressure? And they say, yeah, I'm having pressure all the time. So you got to be careful sometimes on how you word things. So some patients don't see it as pain. They kind of see it more as a tightness or a pressure that they're feeling frequently. Angina lasts several minutes. It's not going to be fleeting. So if it lasts for a second or two, it's like a pulse. You get that, people say it's a stabbing pain that lasts for a few seconds. That's already going to put cardiac or coronary artery disease causing the chest pain that is really kind of lower on the differential. It can't completely rule it out, but it's definitely much lower on the differential. It's usually provoked by activity, right? You got to work the heart. If the heart is being active, you're going to need more oxygen, and so you're going to get pain. And then when you rest, it's going to go away. So it's very predictable. So angina is predictable. It'll come on and come off, kind of like patients know. They'll say, yeah, I don't want to go up those stairs because I know it's going to cause chest pain or chest pressure. You often will get, this classic things, you get radiation to the arms and jaws. Sometimes you'll have nausea and diaphoresis. And the classic teaching is also it's relieved by nitroglycerin, which is true. If it's angina, usually it's going to be relieved with nitroglycerin But nitroglycerin will also relieve other types of chest pain, right? It'll help with esophageal spasm. It can help with a lot of different things. And in fact, they did a study to see if nitroglycerin helped, and it helped oftentimes with non-cardiac chest pain. So you can't put your, just because it's better with nitroglycerin, you still need to get a good story.
Dr. Cheng, we're just projecting a little bit more because they're having a little bit.
They're having trouble hearing? Okay. So, so for non-cardiac chest pain, it's usually fleeting. It doesn't or oftentimes people say they have fleeting chest pain lasting for a few seconds, and that generally is not, usually we don't think of that as coronary artery disease causing that chest pain. If you're having constant chest pain for days, that also is a little bit unusual, right? If you're having constant chest pain for days, then you probably already infarcted. You would have infarcted by then, or it's probably not cardiac. If it's localizable, if it's with movement, those are things that kind of put your differential lower on the list for coronary artery disease causing that chest pain. So again, can't emphasize enough that the history is really important. So one thing about ACS, acute coronary syndrome, and what I want to emphasize here is sometimes patients present differently with ACS, right? Angina is, particularly if it's stable angina or escalating angina, it'll occur with exertion, go away with rest. They generally don't have it with rest. But in an ACS situation, they may have never had chest pain before, right? They might not have had chest pain 2 hours ago. They may have, I've had patients run a marathon 3 hours ago and go to the ER with sudden onset of chest pain. They just finished a marathon. And then they had crushing chest pain, because what happens? If you think about the pathophysiology, you might have had a 20% stenosis 2 hours ago, and that stenosis ruptured. You had a plaque rupture, and now it's 99% stenotic, or even 100% could present with a STEMI, but maybe 99%. It's not going to necessarily present with a STEMI, but you just have chest pain at rest because it's so stenotic. And so patients in these situations, they may not have your classic anginal symptoms. They may just have acute chest pain. And so you really need to rule out ACS. And those are the things that are going to be very helpful for you when you're in the ER. Is the troponin elevated? Is the EKG, are there EKG changes? And if they have sudden onset with no troponin elevation, then that's going to also put you kind of on the lower on the differential that this is acute coronary syndrome, and you're going to start to think, well, maybe this is non-cardiac chest pain. But I just wanted to give that caveat that presentation for ACS can be very different from presentations with someone who's having kind of stable or escalating angina. Are they hearing me okay now?
So, yeah.
Okay. Let me know if they're not hearing this. I can talk to you louder.
When you like face the screen and project, yeah.
So now I'm going to just talk about some cases. So that was kind of the introduction, and we're going to talk about some cases and get people's thoughts. So you're on call, cross-covering for a nurse, or cross-covering, the nurse calls you because you're having this patient's having chest pain. He's uncomfortable. He has no history of CAD, and the sign out says nothing to do. So you didn't get much of a sign out. And the patient wasn't even here for cardiac issues. So what's your next step? You get this call all the time, right? As residents, as interns, someone in the floor that you know nothing about is presenting with new onset chest pain. So again, what would you guys do? Order an aspirin and a heparin drip, call a cardiology attending, order a chest x-ray, order an EKG, order a troponin. Now, many of these things are reasonable to do, but what is the first thing you're going to ask the nurse to do for you? Or again, EKG, right? Because what are you trying to rule out here? A STEMI. Right? You want to make sure they're not having a STEMI, because if they're having a STEMI, even before you go, obviously going to go see the patient, but if you're presenting with an EKG that shows ST elevations, your whole thinking is going to change, right? Because that's a medical emergency. So that is the correct answer. So you ask the nurse for I would also ask the nurse for vital signs as you're talking to them, because that's going to help you decide, is the patient stable? Are they hemodynamically stable or are they unstable? So if their blood pressure is like 70/40, you're going to be, man, I got to go just see this patient's sick, right? If his vitals are more stable, then that's good. And you're going to ask your nurse to get an EKG. And in the meantime, while they're getting the EKG, you want to go look at the old EKG. That's really important. So you always want to look at an old EKG and compare it to the new EKG. For example, if they have a left bundle branch block on this new EKG that you get, if you haven't seen the old EKG, you're really not going to know, right? If that left bundle branch is old, you may not be as concerned, but if that left bundle branch is new in the setting of new onset chest pain, that's going to be more concerning. And then of course, you want to go see the patient. So when you're thinking about and approaching someone with chest pain, I always think about the worst. Think about the things that might kill the patient. And then I think about things that are less concerning, but still on the differential. And from a cardiovascular perspective, the thing I think about the most often time, the thing that we see most often is acute coronary syndromes, patients having acute MI. Aortic dissection should be always on your differential, though it's less common, but it does happen. So it should be in your mind. Does this patient have risk factors for aortic dissection? Is there a reason why this patient might have an aortic dissection? So you should think about it. And then things that can cause chest pain from a cardiovascular perspective, usually doesn't kill you, but it still could be on the differential, is pericarditis. If the patient's hypotensive and having chest pain, you might think about, do they have a new pericardial effusion? Are they in tamponade? And the other cause of chest pain that can happen is patients have aortic stenosis. The nice thing about aortic stenosis is it doesn't happen overnight. So you'll probably already know, though you might have a patient that never sought medical care and then you hear a really loud murmur and you might think, oh, maybe this patient has aortic stenosis. And then of course you gotta think about the non-cardiovascular causes. PE, GI, all those things can cause chest pain. So you go see the patient, and the vital signs that you get is a heart rate of 38, blood pressure of 92/42. He's satting 94% on 2 liters. He's in moderate distress. So this guy's not only complaining of chest pain, but he looks uncomfortable. I have a lot of patients that you go and you see they're complaining of chest pain, but they look perfectly fine. So that's going to be, I mean, patients are very stoic sometimes, so you can't pin your hat on that. But if they look pretty good, you know, usually it's not a step. Usually they're uncomfortable. But this patient looks, he's in distress, he's diaphoretic, his lungs are clear, he's bradycardic, you don't hear any murmurs, and he doesn't have any lower extremity edema, his extremities are warm. So what on this, I ask people in, unfortunately, or maybe fortunately, you're in here with me, so I'll ask the audience here, what thing kind of here stands out to you? Yeah, the bradycardia. Bradycardia is a little bit concerning, right? And he looks uncomfortable. So this is the EKG. I'll give you guys a minute or so just to look at it, just to like analyze it, see what you think. And if I have any volunteers who wants to read it in this room, that'd be great too, but I won't force anyone. Does anyone want to get a stab at this? No brave soul. We're all in a safe environment. It doesn't matter if you don't know it or get it right.
I can go for it.
All right, perfect. What's your name?
Steve.
Steve, tell me what you see.
So obviously I see a narrow complex brady with about 1, 2, 3, 4, 5, 6, 7, 8, 8.6, about 48.
Perfect.
And then it is irregular. And then the most notable things are the ST elevations, 2, 3 ABF.
Great. That's that's notable, right? Everyone see that 2, 3 ABF. There's ST elevations. What else is?
Then I see ST.
I gave this talk multiple times, and I can say you're the first resident that just picked up that ST elevation. So that's great.
Then ST depressions as well, V2, V3, as well as V4, V5.
Yes.
And then the last thing I would be looking at is looking for like any abnormalities in any of the intervals. So I'm looking at the P waves. I don't see any abnormalities there. Looking for the PR interval from here. Can't tell whether it's more than 2 boxes, but it does look a little bit prolonged. The QRS obviously is narrow. QT, I usually just look for 2 big boxes. Right now it looks within no QT prolongation.
So I think you got the big thing. I see those ST elevations. He's bradycardic, you told me. Anything else? Anyone else see anything here that might strike you? Anyone?
Would you consider that PT?
Not really, but I can see like in V3.
Yeah.
Yeah. So why is it irregular?
I'm wondering about progressively prolonging PR.
Yeah, great. So look at the QRS and you can kind of see group beating, right? There's a 2 set here, there's a 3 set here, there's another 3 set, there's a little pause. So when you see something like that and you're bradycardic, you should be thinking of what? Heart block. What type of heart block? Particularly with a group beating like this.
Second degree.
Yeah, 2nd degree. They're probably, so now let's look at the PRs. P, look at that P. Look at that P. There's no P there. There's no QRS. Hopefully everyone's seeing that in the Zoom people too. So P, longer. And then this is probably the non-conducted, and you get a junctional escape. Junctional escape is going to look just like your normal QRS. Then you go back, another escape beat, and you get short, longer drop. Right? So this patient has concerning EKG changes. He's bradycardic with probably a Mobitz type 1 2nd degree AV block. Great. So what's the most important next step? Yeah, great. So good. So that in this situation, the EKG is really helping you, right? Patient's having acute chest pain. He looks uncomfortable. I don't care what his troponin is at this point. It doesn't matter. You're seeing ST elevations that are consistent with the STEMI, right? It's localizable. Let's see if I can go back to that EKG. It's localizable. It's more than 2 leads and contiguous leads, and you see reciprocal ST depressions. So what vessel is this probably?
Right.
What's that?
Right.
Right, the RCA, right? It's probably the RCA. 2, 3, and AVF are your inferior leads, which usually is associated with the right coronary artery. Great. So EKG criteria for a STEMI. So a little bit different based on the anterior leads and every other lead. So remember your anterior leads are really V2, V3, maybe V4, right? Those are your anterior leads. I just usually remember 2 millimeters of ST elevation because most of our patients are going to be over than 40, and at the VA, they're mostly men. But for women, our criteria is a little bit lower, 1.5 boxes of ST elevation. And what's your baseline? What do you consider your baseline on an EKG? Anyone tell me?
Okay, so it's a metric segment between your T and your subscript.
Yeah, perfect. So your TP segment, right? So you're looking at your TP segment. This is your baseline, not your PR. Like sometimes people think they're looking at the PR and they're comparing the PR to the ST, or to the ST change. But you want to look at the TP segment. That's your baseline. That's what you consider your isoelectric point, and you're looking for elevations compared to that. So anterior leads, if they're greater than 40, 2 millimeters. For women, 1.5. And all the other leads, you just need 1 millimeter of ST elevation in at least two contiguous leads. The other thing that you should remember is, we talked about this already, if they have a new left bundle with acute chest pain, not like, oh, I'm having fleeting chest pain. It's a new left bundle, they look uncomfortable, they're having chest pain, you're worried that this is something real, then you have to consider it a STEMI. And the problem is sometimes these patients never had an EKG, right? And you just get an EKG and they have an ST elevations, and you got to consider it a STEMI if they're having chest pain. They just have a left bundle and they're having no symptoms though, you don't need to get very excited. But they're having chest pain, severe chest pain with the left bundle, then you really do need to think about it as a STEMI equivalent. I don't know why I'm having so trouble going to the next slide. So this patient has a cold STEMI. You want to get to the patient to the cath lab as soon as possible. But as the nurses and you're calling the cath lab, they're getting ready. And the cardiologists are coming in now from home because it's in the middle of the night and you're like taking care of this patient. He's uncomfortable. You want to get him to the cath lab as soon as possible. What medicines can you do? Because we all can give medicines. What medicines can you guys do to start him off on in the patient with a STEMI? So what do you want to do?
High dose aspirin.
Perfect. High dose aspirin. Great. What else? Heparin drip. Yeah, you get them on heparin. Anything else? For a STEMI.
Addicts.
A P2Y12. Perfect. So those are kind of your things that you want to think about, right? For a STEMI, because this is an acute thrombosis, right? And the idea of a STEMI is that it's going to present with a STEMI because that whole vessel is occluded. So you want to do the best you can to try to reduce some of that plaque thrombus that's in there, right? Because you think you've had a plaque rupture. So high dose aspirin, like you said. Generally, we want to use ticagrelor or prasugrel rather than Plavix. Why? Because there's been studies that looked at this. For ACS, for acute coronary syndrome, ticagrelor or prasugrel has been shown to be more efficacious in the setting of ACS. And that's really important, in the setting of ACS than Plavix on head-to-head trials. So generally, we recommend either ticagrelor or prasugrel and get them on a heparin drip. You should not delay them going to cath to get them on these meds though. Because this is like, yeah, put them on aspirin, load them with the P2Y12, and if you get them on a heparin drip, great. But don't delay their path to the cath lab, because that's the most important thing, because you want to open up that vessel as soon as possible. And remember, platelets, give them antiplatelets, because once you have a plaque rupture, right, you get platelet activation, those platelets start to clump together. You want to prevent that activation. So you have your aspirin, which does that, and you have your P2Y12 inhibitors, which do that. So they're your antiplatelets, and you're going to start using heparin for anticoagulation. Other things you might think about, right, if they're having a lot of pain, you might give them nitro. Try to relieve some of that pain. You can give morphine. I generally don't give morphine, but you can. If there's not satting well, like they're less than 90%, then put on some oxygen. If they're satting okay, we used to think just put them on oxygen regardless, right? And it can't hurt. But there's been a few studies that actually suggested it might do some harm. I don't really believe those studies, but we don't do it. We don't need to give oxygen if they're satting fine. But certainly if they're not satting well, give them oxygen. And then we talked about aspirin. A beta blocker. You need to give a beta blocker. It's reasonable if they're not bradycardic, if they're not having signs of heart failure. Right? So let's say they had acute MI and now one of their whole walls is no longer moving. Like their anterior wall is not moving. So their EF is now dropped. So maybe it was 60% an hour ago and now it's 30%. So you got to be careful with giving a beta blocker. The idea of giving a beta blocker is really good because it's going to reduce cardiac demand, right? It's going to make the heart have to work less hard. But if your heart's suddenly gone down, really, their EF suddenly reduced and they're in heart failure, it could make things worse. They could put them in shock. So the rule of thumb, if they're hypertensive, they tachycardic, but their lungs are clear and you're not worried about them going into shock, their blood pressure looks good, then I think a beta blocker is very reasonable. And these are just kind of the leads, right? 2, 3, and ABF are really your inferior leads. So we think about RCA. This is for a STEMI, ST elevation MI. Inferior leads, generally RCA. Lateral leads, V5, V6, lead 1, usually circumflex. Anterior leads, V1, V2, V3, V4, usually LAD. Not always, but this is usually the way we think about things. Now, how about ST depressions? So let's say you have 2, 3, and AVF ST depressions. The rule of thumb for ST depressions is it doesn't localize to the lesion. It's not localizable. So sometimes you'll have 2, 3, and AVF depressions and it'll be an LAD stenosis. STEMIs, very localizable. Non-STEMIs or ST depressions, not really localizable. At least that's what they say in the books. I usually seem to localize, but all right. So why is this guy bradycardic? Why does he suddenly have this second-degree AV block? So just kind of remember, this is very common when you have an RCA STEMI, because the RCA gives off blood flow to the SA node, right? So if you have this suddenly occluded, then you're not going to get blood flow to the SA node, you're going to get heart flow. Same idea with LAD STEMIs, because they often supply blood to the AV node, as well as to the septals. So they can cause AV block as well, complete heart block with the LAD territory. And they can also cause a new left bundle. So it just kind of, this all fits, right? Patients having RCA elevations, inferior ST elevations with new onset of bradycardia. The other thing I wanted to point out is when you start thinking about an RV infarct, right? So, and why do we care? Well, regardless of what type of STEMI, we want to get into the cath lab. So you kind of have a big management plan. But if they're having an RV infarct, you might want to be careful about giving them nitro because their RV may not be squeezing anymore, right? Their RV is not working. If their RV is not working, they may need more preload to get blood to the left side so that they'll have cardiac perfusion. But if their RV is no longer working, and you give them nitroglycerin, for example, they can get very hypotensive. So when do we think about it? Well, they have ST elevations in the inferior leads. Then you might want to do a right-sided EKG. And remember, the right-sided EKG, just move the leads, the precordial leads from the left side to the right side, or you can just move V4 to the opposite side. And what you'll see is V4R elevation. And that'll be a clue that this patient's having a right side infarct. It doesn't happen all that often, but when it does, you got to be kind of careful with giving nitro. So if you do see ST elevations in the inferior leads, very reasonable to just automatically do a right-sided EKG. Particularly if you're like they're hypotensive or they're bradycardic. The key point, if they have evidence of an RV infarct, you want to be careful with nitrates. So let's get to case 2. And we probably won't get to all the cases today. That's totally fine. I don't expect to get to all the cases, but they're in there for you to review if you want. So 67-year-old man with a past medical history of coronary artery disease. He had a stent placed in 2019. He presents with chest pain 2 hours ago. Was retrosternal, 7 out of 10, associated with nausea and diaphoresis. He took 3 sublingual nitros before he came to the ER. And the pain was improved, but still there, 3 out of 10. And so he came to the ER, he got some morphine in the ER, and now he's chest pain free. His chest x-ray is normal. His CBC and BNP look okay. and he got a high sensitivity troponin of 100. So I don't think, and you guys can correct me, or you guys may not know, but I think they're not doing high sensitivity troponins at the U or Harborview yet, but we just introduced high sensitive troponins here. So 100 is elevated. I think the upper limits of normal is like 15 or something, or 21, but 100 is not crazy. At least we're starting to get used to this high sensitivity troponin, so everyone in our hospital is getting used to it. High sensitivity troponin of 100 is abnormal, certainly not crazy high, but certainly abnormal. And this is the EKG. So maybe for the sake of time, I will go over it a little bit quicker. So sinus or not sinus? I'll ask you guys. Sinus, right? It's a little bit wavy, but you can see P waves clearly in lead 2. So it's sinus, normal axis, doesn't look too tachycardic, it's narrow. Do I see ST elevations? Not really. Do I see ST depressions? Not really. I see non-specific ST changes. Nothing, there's a little bit of T wave maybe, who cares, right? I mean, we care, but this doesn't give you a diagnosis. And this is what we see most of the time. People say, oh, look, there's a T wave inversion. Yeah, that could be important, or maybe it's just non-specific. But what this does tell me is it's not having a STEMI. That tells me that. So that's very useful. So you go examine the patient. Vitals, a little bit hypertensive, 160/70, heart rate of 88. He looks comfortable now. Got that morphine, no longer have any chest pain. Lungs are clear, heart sounds are normal, you don't hear any murmurs, extremities are warm and well perfused. So now what do you want to do?
Trend the trope.
Sure, you can trend the trope. What's the most important thing? Well, the trope's important. I don't want to say it's not important.
Repeat EKG.
What's that?
Repeat EKG in 30 minutes.
He's chest pain free.
Should you stop?
Well, you got one more. You want to go talk to the patient.
Yeah.
Right? That's the most important thing. You got to see, is this really cardiac chest pain? What's the story? Right? They're having chest pain. Someone calls me and they tell me chest pain. I'll give you guys a hard time. I said, well, tell me about the chest pain. What does it feel like? Is he having it with exertion? What's the most active thing he does? Is he getting chest pain every time he walks around? Or is this a one-time event? How long does it last? How many seconds? You got to know all that stuff. You got to get a history. That's super important. If you just tell me chest pain, that doesn't tell me. I mean, I hate to say it, sometimes ER just goes, he's having chest pain. Okay, that don't tell me much. So give me a history, right? So get a history. So for the last 2 or 3 months, he's been noticing chest pain with desertion. Every time he walks up those hills, goes up a couple flights of stairs, it resolves within a few minutes. That sounds like angina, right? It's predictable, he gets it every time. But now something's happened differently. He noticed chest tightness while just brushing his teeth. Persisted and got worse, even when sitting, felt like someone squeezing his chest. It lasted for over 20 minutes, felt nauseous, and that's when he took the nitro. It's a good story or bad story? Good story for what? Good story for angina? Good story for ACS? What do you think? I think it's a good story for ACS. He's having his baseline angina, so you know he has probably CAD. We already knew he had CAD, right? He had a PCI. He's having angina. This story right here, not that concerning. In fact, I see this in clinic all the time. I don't admit these patients. This is a little more concerning. It's new. It's worse. It's occurring with minimal activity, right? Just doing something else. So in my mind, I'm thinking, did his 80% stenosis that caused angina suddenly plaque rupture, and now it's 95%? That's what I'm thinking in the back of my mind. Or is this just escalating angina? Is it a stable mountain that's just gotten a little bit worse? Or did he actually have plaque rupture? If he had plaque rupture, it's an acute change in his coronary, we consider that ACS. And what's going to help you? Some objective data, like no EKG changes. But we saw that troponin. That troponin was elevated, right? 100. So when are you going to get your next troponin?
3 hours.
3 hours is reasonable. For high sensitivity troponins, you can get it in 2 hours, 1 hour even. It should go up, right? That's the beauty of a high sensitivity troponin. Don't wait 6 hours. Definitely don't wait 6 hours. You can get it in 1 to 2 hours, to be honest. I think the guidelines say something like 2 to 3 hours, and it should rise. Let's say this doesn't rise. Let's say it was 100, which is abnormal, and it's still 100 in 3 hours. When discharge this patient, you say this patient not having ACS.
Was it trying to keep one more?
Why?
I don't know why. I've seen it trending 3 times.
Because we're nervous. We don't believe the data, right? Yeah, I wouldn't fault you for trending again. I do that sometimes. I don't know why. I think the story is compelling here. Right? Again, the story is important. We use objective data. That's great. It helps us a lot. But the story is so important. I think this is enough story where I'm going to say, well, maybe his tropes didn't rise, but his tropes are abnormal. Maybe he has unstable angina, right? So this patient has a great story, and he has an abnormal trope. It's not rising like we do. Like ACS, we think there's a rise and fall in tropes, but it's high. And so I would take this patient in. But look, it did rise. You got a trope in 1 hour, and it went to 1,000, 3,000. Again, 3,000 seems high, but I'm just getting used to these high sensitivity troponins. I've been seeing like real ACS, 7,000, 8,000, 10,000, which was really high, I thought. But when we tapped them, it was not that impressive. But it rose, right? So this patient's having what? All right, so what do you want to do? Is it a STEMI? No. It's a what? It's a non-STEM, right? Non-ST elevation MI. So what do you do? I should give you some choices. So you treat for ACS. Does this patient need to go to the ICU? It's not crazy to go to the ICU because you see that huge troponin, right? But he's stable. Hemodynamically, he's stable. He's chest pain free. He's not having any new EKG changes. So he's probably safe to go to the floor. Of course, you got to talk to him, make sure his hemodynamic is stable, make sure he's not having ongoing chest pain. That troponin is a little bit high, but that shouldn't dictate where he goes. Like he can go to the floor, but what are you going to give him on the floor? It's very similar to STEMI, but there's a little wrinkle that I want to talk about a little bit. So of course, high dose aspirin. Put him on a heparin drip. We say you can give Lovenox, but if you're planning to take the patient to the cath lab, go with heparin. We like heparin better. And it has to do with how much heparin we give in the cath lab when we stent. And Lovenox cloud that. So really, we recommend heparin, a heparin drip, aspirin. Do you need to give a P2Y12 inhibitor? This is a non-STEMI. STEMI, I say, just do it. The non-STEMI, so what do the guidelines say, right? The guidelines have changed. They made it easy for residents. We recommend don't give it now. We recommend giving it, don't give it as pre-treatment. Give it in the cath lab once we define the anatomy, make sure it's real, and then we give it. And why do we do that? Well, ticagrelor and prasugrel are much more fast acting. Plavix is slow acting, so we always like to load it, so to be in their system before we stent. But now ticagrelor is a little bit more fast acting. And the other thing is we did a study, and that study didn't show any benefit in pre-treating. And so that's why they're now recommending don't pre-treat. Now I say that with caution because a lot of our interventionists still like pre-treating. So talk to your cardiologist. But usually if I'm taking that patient to the cath lab within 24 hours, I will not pre-treat I won't load them. It's not a big deal if you do load them, to be honest. But if you see like they need surgery, that's another reason we don't do it. You want to delay their surgery. To be honest, in our system, it's very rare that we take someone to surgery within like 2 or 3 days after an onset. But sometimes it's possible.
We have like 2 minutes left, just as a timer.
We only have 2 minutes left?
I think so. I think it's 11:45.
Oh, shoot. Okay. I did not know that. I thought it was an hour. Give them high dose statins, right? You want to do that. You also could consider a beta blocker, echo. And then you can get more labs if you want. You probably should. And then when you place this patient to the cath lab. So we think about non-STEMI management. We think about revascularization strategies. There's kind of 3 different time points that we think about. We think about immediate invasive, we think about early invasive, or we think about maybe you don't even have to take the patient to the cath lab. Maybe you can just do a stress test. So how do we decide? Well, if they're having refractory angina, if they have hemodynamic instability, or they're having electrical instability like VT, we want to take them to the cath lab soon, urgently, within 2 hours, 2 to 3 hours. So it's in the middle of the night at the VA, we don't have a cath lab in the middle of the night, and you're seeing them have VT, they're having troponin elevation, gotta send them out to Harborview. Now, if they're stable, and they're hemodynamically stable, they're not having any more chest pain, then you can calculate their GRACE score. This is where that GRACE score, that TIMI score is useful. It's not to determine if they're having ACS, it's to help you decide what to do once you know they have ACS. So their GRACE score is high, or their TIMI risk score is high, over 2. And it doesn't take much to get them to those points. And you really want to do an invasive strategy, get them to the cath lab within 24 to 48 hours, preferably 24 hours. And then if they have a very low risk ACS event, their TIMI score is really low, you could argue that you don't need to take them to the cath lab. You could do a stress test and figure out how much of their heart is vulnerable. Do they have a large territory of vulnerability? They have a large territory of ischemia. And if they do, you might take them to the cath lab. If they don't, you could just say, let's treat them medically. And the reason we sometimes do that is, let's say this patient has a creatinine of 5. They're not on dialysis yet. So I don't want to put them on dialysis. So if there's a low risk ACS event, I might just stress them and see how ischemic they are before deciding to cath. So you're now on the night float intern, and the patient signed out to you at 10 p.m.
Yeah, we might have to pause. I'm sorry, Andrew. It's we're at 11:47, so we might have to call it.
Okay.
But thanks so much for going through STEMI and NSTEMI. Do you mind going to the very last slide that you have with your QR code? Because we'll just ask people to do some evaluations, and then any questions that they might have would be great.
There's 4 cases total, but we only got the 2. It's okay.
Does anyone have to sign a sheet? Okay, they don't sign it, because I can get reimbursed.
So if people have any questions? I totally thought it was an hour. But it's okay. This is just an approach. And this really just takes experience. No questions? It was all clear.
Can we get the slides? Yeah, they get posted in the drive. I can send the link to that.
So the other case, we were basically done with the non-STEMI. The patient was going to have more chest pain. I recommend giving nitro, and if they're continuing to have chest pain, gas take it to catheter. And then there was a pericarditis case, and then an aortic dissection.
Thank you, Emily. Thanks, Dr. Cheng.
Yeah, thanks so much. Well, I'll post the slides and the recording on the YouTube playlist. Have a good day, everyone.